Let's go ahead and get started. I'm Shane Shapiro. I'm a physician at Mayo Clinic, Department of Orthopedic Surgery, Mayo Clinic in Florida. I take care of the University of North Florida in Jacksonville. Joined today by colleague Paul Sines, who's with Sports Medicine Associates of San Antonio and takes care of the San Antonio Spurs. We are self-moderated today. The topic of our discussion is the use of stem cells in sports medicine. I think it would be perhaps more appropriate to call it use of stem cells in sports medicine and orthopedics or musculoskeletal medicine, because certainly our patients that we're all treating, they're not just elite athletes. We take care of a number of musculoskeletal conditions. And so I'm going to try and give everybody an overview of what's going on in 2014 with regenerative techniques in orthopedics and sports medicine. We'll talk about what's been done in the past, what is our current stem cell use, try and do a little bit of scientific evidence that either supports or refutes the use of some of these techniques. And then Dr. Sines is going to present several cases that I hope will illustrate how we're using these techniques currently and also spark some discussion. This is a very, very broad topic. There's a lot of areas that we probably won't get a chance to cover, certainly in my aspect of it. But I'm going to move very fast through this because I think a lot of us here are here more for the discussion than actually to hear what I have to say. And I think that if we can leave a fair amount of time at the end of this hour for some healthy discussion, I think that will benefit all of us. Please, if I'm moving too fast and if there is something that isn't quite clear, just stop me and I will certainly go back. So how did we all get here? Well, speaking for myself, and I think probably speaking for a number of sports medicine physicians in the field, this is how I got here. This is a New York Times article from 2009 in February, which came out about a week after the Super Bowl in which the Pittsburgh Steelers played the Arizona Cardinals. And the topic of this story were two Pittsburgh Steelers, Troy Polamalu and Hines Ward, both of which had fairly significant soft tissue injuries in the AFC Championship game 2 weeks before the Super Bowl. Both of these underwent a fairly novel autologous procedure called platelet-rich plasma injections and recovered perhaps a little bit quicker than their physicians would have expected them to recover, and were able to play and play quite well in the Super Bowl that year. The New York Times got hold of this, and this was on February 17th, I think, and on February 18th I had multiple patients in my office holding their copy of the New York Times, all of them over the age of 75 or 80, asking me if I could perform this procedure on them. And so that was sort of the PRP explosion, and since that time we've done a fair bit of work with platelet-rich plasma. Obviously this is a regenerative technique, it's not a stem cell technique, but I think this is, to use probably a very poor analogy, this may perhaps have been the slippery slope that brought a lot of us into the use of stem cells. So platelet-rich plasma involves the centrifugation of venous blood into its three component parts, the red blood cells, platelet-poor plasma, and then the platelet-rich cells, which are concentrated cellular portion that contains the ability to release growth factors and alpha granules. These are precisely re-injected into areas of pathology, whether it be torn ligamentous structures, torn soft tissues, or even joint use. Is everybody able to see the lights low enough? Good. So, not to discuss PRP or the scientific background behind PRP, but at least at Mayo Clinic, we've had a very nice experience with this. My colleagues in Rochester published this in Physical Medicine and Rehabilitation. I believe it was either in 2011 or 2012, where we did some retrospective follow-up of our use of PRP in multiple areas. And we found that the results were certainly satisfactory, with a large majority of our patients satisfied with their pain relief. It is a regenerative technique that typically does require several months to improve from, and does also typically accompany some form of physical therapy to help with that improvement afterwards. Of note, from the regenerative standpoint, a large percentage of the patients that got better did not demonstrate improved appearance on imaging studies, and that did not necessarily correlate with the people who got pain relief. So a lot of people improved, but some of the people that improved, their pictures didn't get any better. Some people whose pictures got better, they didn't improve from a pain perspective. So from the PRP, we perhaps very quickly, before all the science has been worked out with PRP, shifted to BMAC, or bone marrow aspiration and concentration. And the reason that we transitioned to this is because, using some of the similar techniques from PRP, specifically density gradient centrifugation, we can take a different source, bone marrow derived usually from patients' iliac crest, and we can spin it down with the same machines and get concentrated cellular material, much like the PRP, but the bone marrow comes with the added benefit of containing higher quantities, higher numbers of mesenchymal stem cells. And I think, stem cells is why we're all here at the World Stem Cell Summit. So now we have the ability to concentrate these stem cells. What then can we do with them? We certainly all here believe that and have demonstrated that MSCs contained in the marrow have some regenerative capacities. We know that they also have some trophic effects, some anti-inflammatory and immunomodulatory properties. And additionally, some of the HSCs, the hematopoietic stem cells, can also play an additional regenerative role, even though they go onto a different line than we are interested in the musculoskeletal world. Some of these anti-inflammatory properties and maybe vascular properties can also be promoted by HSCs. So as I said, this is certainly caught on in the sports medicine world. It's a very hot topic of discussion. Very regularly you'll see in the lay press, ESPN, the magazine, Sports Illustrated, discussion of the use of stem cells in our high-level athletes. Here's a quote from orthopedic surgeon Dr. James Andrews, who has said on a number of occasions that he believes this is the next great frontier for sports medicine, akin to the use of the arthroscope over the last half century. And of course, if you have leafed through your World Stem Cell Report from 2014 that we were all given, we see a table of NFL football players who have publicly acknowledged the use of stem cells for their injuries or during the course of their recovery. And so very much moving into the mainstream, even though we don't have all the science to support it. So as I try and organize this in my head, we think about this R3 repair paradigm. This is a representation of the human regenerative map, whereby we certainly know we have the capacity for self-healing. The last 50 to 100 years of musculoskeletal injuries, we repaired by replacing. So if you think about ACL reconstruction or ulnar collateral ligament reconstruction, that's a replacement. And so the next phase, or the next leaf in this paradigm, is regeneration. I think most of the people here attending have seen some representation or illustration of a drawing such as this, so I'm not going to belabor this point, other than to say that not all regenerative techniques involve MSCs. We have a number of other possible avenues to get to where we're trying to get. Glossary of stem cell platforms. I hope most of us in here are familiar with what embryonic stem cells are, what adult homologous stem cells are, allogeneic stem cells, and then bioengineered stem cells. The limitations, of course, with embryonic stem cells and a type of stem cell that often gets derided in the press is the embryonic stem cells. But beyond the ethical consideration, one of the reasons why we're trying to work with adult homologous or autologous MSCs is that embryonic stem cells are difficult to work with. So before we move on into the specifics, just a little bit of alphabet soup in terms of what type of cells we're using in the sports medicine world. I already mentioned the BMAC. I think most of you who've been here for a couple of days have heard a number of talks at this point on the adipose-derived stem cells. There is some early use for soft tissue applications of the dehydrated amniotic tissues that can be applied in several fashions. All right, so why are we doing this? Is it just about getting high-level athletes back onto the field quicker than we would otherwise expect them to? Of course not. Most of the people who are coming to us to ask for help are not necessarily high-level athletes. They're the weekend warriors, and they're also our older patients or our post-traumatic patients who are starting to degenerate in certain parts of their musculoskeletal system. And so we're looking at intra-articular applications of this too. Most of us, I'm sure, are familiar with the burden of arthritis or degenerative joint disease, that this affects millions and millions of Americans. So these techniques that we're trying to perfect are not just being applied to our high-level athletes. They're being applied to 67 million Americans, hopefully at some point, who we may be able to treat with these regenerative therapies. Why? Well, we have an aging population. If you look at our world map and what it looked like, what it looks like today, and what we can expect the world to look like in 2025, a much more elderly population. We know that the joints are going to degenerate. We know tendons are going to degenerate, and these patients are going to be coming to us asking for their help because we can't just slam arthroplasties in all of these joints. It causes skyrocketing healthcare costs, and those costs have to be paid for by all of us. So I want to progress real quickly to talk about why we're in this field. And the reason for that is currently, for a lot of these degenerative conditions, we don't have very many good non-surgical options. So the American Academy of Orthopedic Surgeons in September of 2013 released their recommendations for the non-operative treatment for osteoarthritis, and it's not very good, or there's not many of them. Not to say that they're not good, but you've got physical therapy, you've got gentle pain relievers, and you have steroid injections, and then that's it. And then if those things fail, these others are now not recommended. Many of them are falling off of the reimbursement platforms for our insurance carriers and Medicare, and then we can't get paid for them, or our patients have to pay out of pocket, or they end up getting a knee replacement. So we have to get somewhere where we have some options to slow this tide. One of the earliest regenerative therapies for orthopedics is autologous chondrocyte implantation, and that's been performed since the 1990s. We've had great success with this surgical treatment for rather smaller defects, but there are limitations. This is regrowing cartilage, so people will come to me all the time in my practice and they'll say, "Hey, I heard you can regrow cartilage in my knee." Well, in fact, we've been doing that for many years at this point and doing it quite well. Some in this audience better than I can do, certainly. This is a culture-expanded chondrocyte preparation. It requires 2 surgeries as it's being done most of the time presently, and long-term follow-up is pretty good, but it's not great. And so the most current number that I've seen in this is approximately 50% survival of these grafts at 10 years. So now contrast that with the BMAC and why we're so excited about that. This is a theoretical advantage. Using stem cells to differentiate into chondrocytes. So then rather than getting the patient's own cartilage with the surgery, growing it up in culture, and then reimplanting it, perhaps with one surgery we can use MSCs to stimulate the growth of chondrocytes. Might be able to apply it to larger lesions, so more diffuse osteoarthritis. It is definitely less invasive, but we don't have any randomized studies yet to even make any claims at all that this can compete with the studies that we've done in the past decade with ACI. There is one good head-to-head study out there. It's from 2010, American Journal of Sports Medicine. This was non-randomized. It was a cohort study. We had 36 patients in each group. They did BMAC, and it was culture-expanded BMAC, and compared it to how their patients with ACI did. And what they found is, and at least in terms of quality of life, the outcomes were equal. They didn't do any imaging. They didn't do any synovial fluid analysis. They didn't do any histological investigation. But they did find, from a pain perspective, that these things did about the same. Now, I don't necessarily know what to make of that. It's obviously much easier to use the BMAC than it is to use the ACI. But because this wasn't robustly studied, I think it's very early to see or say how BMAC measures up to ACI. So that's where we come in, because right now we're conducting our own study where we're using BMAC and we're injecting the bone marrow into osteoarthritic knees. We are doing this in a randomized fashion. It is blinded. It is placebo-controlled. So all of our patients have bilateral disease. We're taking BMAC. We're not culturing, but we're concentrating it in a fashion. We're re-injecting it blindly into one patient's knee, and then their contralateral knee is getting saline. Okay? So we think that this is sort of the first stage in offering up the FDA the type of science that they're looking for to support some of these techniques. So here's our marrow aspiration, right? And then we're spinning it down using the exact same centrifugation device that we would be using for the PRP. We do have a filtration process. We hope to separate out those different layers of cells. I'm aspirating the knee. I'm taking a pre-injection synovial fluid analysis. So we're looking for we're looking for markers of osteoarthritis and inflammation. Then we're re-injecting our cellular portion into the knee. And we're studying this not only with quality of life, not only with post-injection synovial fluid analysis at 1 week and at 6 months, but we're also going to MRI these people, and we're going to use very sensitive quantitative T2 mapping strategies to hopefully get some idea of whether or not we're getting any real improvement with this BMAC procedure. So we've nearly completed our first phase, which is a feasibility study, a trial study, and we're making good progress. We've got generous funding from Mayo's Center for Regenerative Medicine, the help of our Office of Research and Regulatory Support has been unbelievable in terms of navigating the FDA, because the regulatory aspects of this are very challenging. The FDA has told me personally this is not homologous use. Okay, this is not a minimally manipulated procedure. As far as they are concerned, doing this, which many of us are doing in our practice, requires an IND. And so we applied for the IND, and we've been awarded the IND, and we've nearly completed our trial. We got some very, very early data out of this. We've now done enrolled 25 patients, injected 23 of them. And what we're seeing is that our viability is quite good. So we're having a very healthy harvest of the marrow. We're getting about 41% mononuclear cells. If you look at the difference between pre-concentration and the post-concentration, in terms of mononuclear cells, we're injecting about 60 million of them. Okay, but here's where it gets a little disappointing. If you look at our percent MSCs, they are really quite low. Okay, this actually mirrors or reflects other studies in the literature to suggest that even concentrated MSCs are a very, very small proportion of these mononuclear cells. So the patients are coming to us for stem cells, and what we're doing right now, yes, we're using MSCs, we're using stem cells, but not nearly to the numbers that we think we need to be having in order to regenerate tissue. So here's another couple of high-profile athletes, both of which had avascular necrosis of the femoral head. Here's another study that we have going on at Mayo Clinic right now. This is AVN of the femoral head. These are my colleagues in Rochester, and what they're doing is core decompression of the femoral head at the level of the AVN, and similar to our use of the BMAC, they're injecting this intraoperatively into the surgical site, and their outcomes have been outstanding. If you look at these 4-year post-op images of this very same patient in their AVN, stage 1 or 2, they're getting excellent outcomes. This data is a little bit old. This is my 2012 data. We've now done hundreds more, but of our early experience, 80 hips, 55 patients, 2-year follow-up, 77% of these are healed. 23% did go on to collapse, and many of those required hip replacement. But all in all, they're doing quite well. So another application of the BMAC and the use of MSCs that we think is quite promising. As we continue to study our use of MSCs, as I mentioned before, we're probably going to be moving on to seeing if we can do this without bone marrow aspiration. Can we do it in a more readily abundant, perhaps less painful manner by using aspiration? But again, our early studies of even the adipose-derived stem cells still show that those numbers, the percentage of MSCs that we are getting out of this process, are still quite low. And therefore, what most likely has to happen is moving on to a cultured product. Excuse me, so got that out of order. So we'll talk about culturing. The placental-derived products that I mentioned before, there are many, okay? This is not directly an MSC product, okay? We don't know necessarily if there are any MSCs or what the percentage of MSCs are, but this is another growth factor delivery device, or a growth factor signaling product, if you will. And we know that these are immune-privileged tissues and that they have a lot of the same growth factors that we see in PRP. And so a lot of people who are using these consider these to be progenitor cell signalers. So by bringing in the amniotic products, we can recruit our stem cells, and maybe that's easier than working directly with the MSCs themselves. Only time and research will tell if that is the case. From my own perspective, having gone through this, I can say we're all waiting on the allogeneic product to spend some more time in the lab and in clinical research. This study, the Van Ness group, did post-arthroscopic meniscectomy use of one of Osiris's product. This is an ex vivo cultured MSC. They had 3 arms. They had a control arm, an arm where they injected 50 million cultured MSCs of their product, and another arm with 150 million. And what they found was some nice improvement if you look at their imaging, and also statistically significant difference in VAS reports. I put up here that they have 427 adverse events. I've not spoken to the authors of the study. That's obviously a lot. Now, what we can do, though, is infer that a number of these, and I think it was mentioned in the article, a number of these are post-operative complications, normal things or common things that you might see post-arthroscopy, but still a fair number of adverse events in the 52 subjects, with 28 of them being severe. So when we talk about an allogeneic product, not homologous autologous use, we need to be sure that we're protecting our patients and that we do the studies. There's a South Korean product called kardesim that, from my understanding, is receiving attention and clinical trials in the United States, and perhaps someone may know more about that than I do. We can discuss that afterwards. So what's next? I mentioned the induced pluripotent stem cell. We've had a number of great talks at the World Stem Cell Summit here already this week about the use of iPSCs. That's certainly an excellent avenue. I mentioned the culture expansion of the stem cells and the promise of perhaps more is better. Is allograft the way to go with this culture expansion, or do we try and continue to be autologous? I don't think we really know the answer to that in our field. But I do want to quickly make point about stem cell regulation. As I mentioned, for our study, which we thought was minimal manipulation, homologous use, the FDA disagreed with us, and so there is the Center for Biologics Evaluation and Research that they're looking at these studies that we're doing. These are HCTPs, and they fall under the Code of Federal Regulation 21 CFR 1271. And if you don't meet that criteria, you require an approved biologics licensed application to market your product for these uses. And that requires doing the background research, getting an IND, making sure that you have good tissue practice and good manufacturing practices of your facility. The other thing I'd like to point out about the FDA before I turn it over here is that right now there are no actual FDA-approved BLAs for any MSC product. Okay, we have a lot of other products that have received BLA. None of them, to my knowledge, this is as of January, so if anyone in the audience knows of something more recent, none that contain MSCs yet have the ability to be marketed for such. The FDA also tells us, hey, when you're publishing these studies, you guys need to get consistent in what you're calling an MSC. Because up to this point, if you review the literature, the markers are all over the place. And the FDA has lamented the fact that we cannot standardize our research. So what one person says in their study is an MSC, and they say, oh, well, we have 1 million MSCs that we were able to concentrate. And then I come back and I say, well, we've got numbers that are actually quite lower out of our study. What we have is a disagreement about what actually is an MSC. And we need to standardize that using markers that are acceptable to the FDA, because if they're the ones that are awarding the INDs, if they're the ones awarding the biologic license, you got to get it past them that it is actually an MSC, or you can't market it as such. So we need good studies. We're trying to do those. We need to develop standard operating procedures. We're doing that as well. We need to go through the IND process. This is very difficult, but it has to be done. If we're going to treat 63 million Americans with a treatment for their musculoskeletal conditions, we're never going to be able to do it by treating one person a month who can afford to come pay large sums of money for this out of pocket. We have to come up with something that is going to meet the code of regulations that can be applied to a large number of people. So I hope that this, as well as Dr. Sines' cases now, will stimulate some discussion about whether or not we own our own cells, whether or not we're dealing with biologic drugs or surgical procedures, and what the current state of stem cell use in sports medicine is right now. So with that, I'm going to turn it over to Dr. Sines, and then we'll have discussion at the conclusion.